Thank you very much. I'm deeply honored to be here today with you and to be a special guest of Debashish, of the President of the Society. I hope we will be resolving our issues quite soon. I will be talking about, again, I want to thank Mr. President for the kind invitation to have this talk. I will be talking about pupil expanders, but first I would like to say that there is a good phrase that what counts in life is not the mere fact that we lived, but is what difference we made to the life of others. And definitely I would go back a little bit into the history of ophthalmology, and the man that showed here with the arrow is Professor Fedorov. You may know him. He is a founder of our institution. He was quite famous for pioneering different intraocular lenses, like this Sputnik lens, as you can see here from this slide. And then you can see him created different lenses, and there were many more lenses that were being done in our institution over these years. They were developed in our factory. And also radial keratotomy, as you can see here. Radial keratotomy is the technique that was used to correct myopia for many years, but of course it's not used anymore. But definitely this technique changed the mindset of the people, and from then on there was a shift of paradigm, and the people were considering refractive error as being the surgical procedure corrected. So there were some other innovations like conveyor system. This is different conveyor belts. When the patient was lying down and was rotating from surgeon to surgeon, and this was widely criticized in Russia and abroad, and definitely we are not using it anymore, but the idea of this conveyor system was quite good, because when you have limited resources, you have limited number of surgeons and a lot of patients you have to serve, you have to think how to utilize them more effectively in order to serve a bigger number of people. So that was one of the ways that we learned from the industry, that this system may help to enhance the productivity, and we're still using this type of conveyor diagnostic belt in our pediatric departments, and kids love to move from one station to another and to have a lot of fun during diagnostic procedure. And then mobile diagnostic units, as you can see here, this is a ship, buses and a train that were traveling all over Russia, and definitely the microsurgical institute that was built from the scratch and this is now located in one of the northern parts of Moscow, with the main building, auditorium, polyclinics, and hotel, and the facilities, manufacturing facilities, and there are some other buildings that are not in this picture as well. But after that, it was a eye microsurgery complex, which is consisted of 11 branches that were installed all over Russia. You can see that Russia is can be divided into two parts, which is 1/3 of Russia. Here is the Ural Mountains, which is European part, and this 2/3 of Russia, which is Asian part of Russia. And with these areas are not very much populated. That's why we don't have branches here. And with time, the complex grow, and we are now having a lot of satellites all over the European territory, and doing a lot of surgical procedures a year. This is how the typical branch looks like. This is a 6-story building with inbuilt diagnostic and surgical facilities. We're still using these operating rooms that are big enough. We're not using them in the conveyor belt manner, but we are using them as an individual for each patient. And also we have some individual rooms for vitreoretinal surgery. We train about 90 residents a year, and hosting major national congresses in Russia, and printing Russian language ophthalmic journals, and having laboratory facilities with eye banking. We do around 500 corneal transplants per year. Only in Moscow, and also we are having manufacturing facilities. We produce our own viscoelastic lenses and so on, and that's helped us to keep this spirit of innovation when the clinical research and manufacturing and education are binded in one in-house in one facility. And now I would like to come back in time and to share with you some pictures of the Indian journey, because in 1987 at one time buses were traveling all over India, and Fedorov was doing some demonstrative surgeries here, demonstrating his technique of cataract extraction and IOL implantation. Here's with Rajiv Gandhi, and probably you know and recognize some of these people pictured here. And also we have Indian delegates coming to our institute, and in spite of the cold weather, you see, the Indian guys were well prepared for this cold weather that was in Moscow at that time. So we want to keep up the traditions, and that's why we are having close contacts with the All Indian Ophthalmology Society. We're holding the sessions, joint sessions during the Russian congresses, and the sessions during All India Ophthalmology Society congresses. And these are the delegates visiting us in Fyodorov Museum, and some of them visiting our wet lab facilities and enjoying interesting interactions with the colleagues. So, coming back to the talk of my lecture, does all this stuff somehow related to the small pupil? Not really. Now I'm going back to the topic that I will be discussing. So small pupil, definitely we know it's a challenging situation for the cataract surgery. But what about this patient? This is patient does not having small pupil, but definitely he will be presenting a lot of challenges for the cataract surgery. So in certain clinical cases, the numbers of how small should be the pupil are misleading. And this is intraoperative floppy iris syndrome that was introduced to us by David Chang. And we know that this is a very, very challenging condition. With regard to the pupil expansion devices, there are many, and many more are coming. And probably iris hooks are the most widely used iris expansion device that are currently available on the market and used by many surgeons. And these devices are quite effective, not only in holding the pupillary margin in place and expanding the pupil, but also hooks can be used to catch the capsulorhexis and attach the capsular bag to the limbal area. Although I will recommend using specific capsulorhexis hooks, capsular hooks for this purpose. These are some disadvantages of the hooks when they are overextended. So you see that the hooks are actually lifting the iris above the surface of the lens, and when you're entering the eye with the instruments, that may cause some difficulties during the procedure. So it's advisable not to overextend the pupil to avoid this condition. Also, you have to watch paracentesis angle. With proper paracentesis angle, you can avoid this as well. The other issues with the hooks is usually it creates a square pupil. What's bad with the square? As opposed to the circle, the perimeter of the square is much bigger, and that's why with the square pupil you have a tendency to overstretch the iris tissue and create microtearing, and then cause trauma to the iris and cause posterior synechia formation. That's why trying to keep the pupil round is a good idea, which was utilized by many different devices and pupillary rings with the main concept of keeping the pupil round and holding the pupil in place, expanding it, and protecting the iris margin with different designs of grooving or special elements on the outer portion of the ring. So here comes the other device, which is bearing my name, and this device is single-used. It stays in the holder, and we are using injector to retract it from the holder and place it into the eye. Then this device utilizing tissue capturing principle of paperclip, as you can see here, and it goes in different sizes, 6 1/4 and 7 millimeter. I do prefer the smaller ring, while the bigger one is great to use for intraoperative floppy iris syndrome cases when the pupil starts off bigger. And this device holds the pupil at the corners of the device, but also, as you can see here, it provides you a very nice round pupil. Why is that? This is because in the middle between two corners there is additional point that holds the iris. So actually this device is equal to eight iris hooks, and that's why it's stretch the pupil very gently and does not over traumatize the iris tissue. This is the technique of ring implantation and removal. I do like to position the tip of the device quite close to the iris margin, and then inject the ring. And while injecting the ring, I'm slowly retracting the injector backwards in the direction to the main incision. And at that particular moment, usually two lateral scrolls are engaged with the iris automatically. And what you have to do now is just to use your side port instrument, special manipulator, Kuglen hook or Lester hook, in order to place the ring, the last scroll of the ring, and to after the case is completed, to remove the ring, I like to disengage the distal scroll first, and then followed by the proximal scroll. There is no need to touch these lateral scrolls, because as soon as you will remove the device from the eye, they will go out of the contact with the iris automatically. You catch the proximal scroll with the hook of the injector, and then slowly retract the ring inside the injector. It's quite important to be aware when you're using smaller incisions of 2.2 or less. It's better to press on both lateral scrolls so the ring goes inside the injector tube completely, and you will have no issues in removing the device out of the eye. So these are advantages that are summarized here: 8 fixation points, no sharp edges, minimal trauma to the iris tissue, reliable clamping mechanism. The device is flexible, injectable, and having low profile. That's why no trauma to the endothelium is occurred during the surgery. So now there is a growing evidence that then in modern cataract surgery, which is a femto laser-assisted cataract surgery, surgeons are using this device more and more, like in this particular case when the device was inserted at the very beginning of the procedure, and then laser step was done. I do personally use this device only in cases when the pupil constricts in between the laser step, or when you perform femto, capsulorhexis, nucleus fragmentation, and then patients arrive to your operating room and to your table, and you see that the pupil is not sufficiently dilated. So that is the technique that I use. I use it to expand the pupil, and you can see that the capsulorhexis, which can be visualized very nicely with the laser step of the procedure. Of course, you have to be cautious, because when you are implanting the ring after capsulorhexis being performed, there is a chance that you can catch the capsulorhexis. So definitely you want to avoid it. Luckily, with the laser capsulorhexis, it's a little bit grayish, so we can identify the edge of the capsule much easier than with the manual capsulorhexis. When you're inserting the ring after manual capsulorhexis, for instance, when IFIS syndrome and people starts to constrict and you need to implant the device. So that is a little bit different. So after inserting the ring and expanding the pupil, the next steps of the procedures are quite routine. You're checking your capsulorhexis for any residual adhesions. Usually there are no, and then you are performing the next steps of the surgery. Again, to remove the device, it's possible. It's advisable to disengage the distal scroll, as shown here, then followed by the proximal scroll, and then you lift the ring a little bit above the iris plane and use the same inserter to catch the proximal scroll of the device and retract it inside the injector tube, and then remove the whole assembly from the anterior chamber. Then you definitely removing residual viscoelastic, and you see that the pupil is perfectly round, it is centered, and no major trauma happened during the surgery. So definitely we have to look to the future. This is because this is the place we will spend the rest of our lives, and innovations never stops. And I was glad to see that this concept was based for the other innovations, like the rings that you can see here. There are different devices that are currently coming to the market based on this concept. So coming to the question that I asked you at the very beginning, does size really matter for cataract surgery? And the answer is not anymore, because the Malayugin ring makes things bigger. And I thank you for your attention.
Thank you, Boris.